Okay, well, we've reached 5 past, and there's a good number of people on the call today. I wanted to talk about anemia in children. It's really common. It's as I said in the summary, it causes a high proportion of it's a factor in a high proportion of deaths that occur, and I think we often have a fairly simple view of anemia, but I think we need to have a bit more detailed understanding of anemia because it just is so common in children. So today I want to discuss all about anemia, all the things you need to know. I'm particularly going to go back a bit and discuss some aspects of physiology of hemoglobin and iron physiology and oxygen delivery, just some basic physiology so you'll understand that. We'll talk about assessing the child who has anemia. We'll talk a lot about iron deficiency, and we'll talk a bit about thalassaemia, so you have a good understanding of those things. We'll touch on G6PD deficiency, and we'll also talk about indications for transfusion. So that's the outline of the talk today. All very practical, I hope. First of all, a bit of theory. When we are thinking about anemia and hypoxemia, we need to understand what the oxygen delivery equation is. And because you only have hemoglobin to carry oxygen, you have oxygen so that there's oxygen delivery to tissues, and the factors involved are for oxygen delivery to tissues are the cardiac output times the hemoglobin times the oxygen saturation. And so if one of those is down, then sometimes there'll be compensation with the other factor increasing. So for example, if a child is hypoxemic, then often their cardiac output will increase because they have an adrenaline surge and they have a high stroke volume. If they're chronically hypoxemic, then often their hemoglobin will increase. So you see children who have tetralogy of Fallot, for example, that are chronically hypoxemic, or children who live at very high altitudes that are chronically hypoxemic, their hemoglobins are often 15, 18, 20. So the oxygen delivery equation is very important, and we need to sort of understand the components of it. So the oxygen delivery, don't worry about the units, but it's in mils per minute, equals the cardiac output, and that equals the heart rate times the stroke volume. So now that we are learning a bit about echoes, we understand what stroke volume is, but the heart rate times the stroke volume is the cardiac output. This factor here, 1.31, is the amount of oxygen in mils that's carried by 1 gram of hemoglobin. It's just it's a constant. Whereas the things that change are often the oxygen saturation changes, the hemoglobin may change, and the cardiac output may change for lots of different reasons. If you can think of lots of reasons why the cardiac output might change because of sepsis, because of dehydration, etc. You can think of reasons why the saturation may change and the hemoglobin may change, may fall because of lots of reasons. So if we understand that it's all to do with maintaining an adequate oxygen delivery to tissues, then we'll understand the components of the oxygen delivery equation. Okay. Hemoglobin's complicated in children because it's not the same as in adults, and there are changes in the hemoglobin normal hemoglobin concentration with age. And I'm sure you all know this, but babies start with a hemoglobin that's higher, generally speaking, than adults, and higher than it will be in 6 to 8 months. This is normal changes in hemoglobin. This is a study that was done in Kenya looking at the normal hemoglobin in children of mothers without placental malarial infection, and then children of mothers with placental malarial infection. And even those well mothers, the babies of well mothers, their hemoglobin dropped, and that's because of the fetal hemoglobin that dissipates over time, and then what you're left with is adult hemoglobin. Of course, it is a bit lower if the mothers have placental malaria, but the point I want you to notice is that the hemoglobin starts around about 140 grams per litre or 14 grams per decilitre. It's important to know the units, 140 grams per litre or 14 grams per deciliter. And then it falls, and this is a normal fall, up until about 6 to 8 months of age, where it reaches what they call the nadir, which is the lowest point, and that's around about 95 to 115 grams per litre. And then by 2 years, it's back up to 115 to 125. That's by 1 to 2 years. And then there's a further increase in hemoglobin as the child gets older. This was a study, this one is a study done in India, a very large study, of a community-based study looking at the changes in hemoglobin in many thousands of children that occurred between 1 and 19 years. So all throughout childhood and into adolescence. And you can see this was the increase, the average increase in hemoglobin levels in boys and the average increase in girls. And these are the WHO standards for what constitutes a normal hemoglobin. The line in blue is the WHO standard for what constitutes a normal hemoglobin. And you can see that the children in India, the boys were a little bit below the WHO standard on average. And of course, some of the children were close to the WHO standard or equal to that, but this is the average. And girls were substantially below the WHO standard, and especially as they got into adolescence. You can see the gap between the WHO standard and the average hemoglobin widening. And it's not surprising that that occurs around about puberty and around about the first menstrual period. So this is important for girls, that boys have a boost in their hemoglobin when they get to adolescence, and girls tend to need more. Now, if we're going to talk about the pale child or the child with anemia, then the first thing to think about is the child sick or well? Now, the reason I show these two photographs is because the boy on the left, this teenage boy on the left, he had the lowest hemoglobin I've ever seen, and that was 1.6 grams per deciliter, right? 1.6 grams per deciliter, very low. And you can see he's showing us where you can look for anemia. So in the palms of the hands, in the mucous membranes of the tongue. He didn't show me his eyes, but they were very pale as well. All right. And the striking difference between these two photographs, this boy was 1.6 grams per deciliter, and this small baby was also very pale at the time of birth, but his hemoglobin was 6 grams per deciliter. This small baby looks sicker than the teenage boy. And so when you're thinking about a child who's pale or a child who's anemic, you need to ask yourself, is the child sick or well? And that can tell you a lot about the rate at which anemia has occurred and the degree to which the child is compensated for that anemia, and also the presence of other associated conditions. Like this baby had gram-negative sepsis and was anemic because of that. And this child had a chronic process of anemia, probably a chronic hemolytic, slow hemolytic process that happened over many weeks or months. And so it compensated reasonably well for that. So when you're assessing a child with anemia, we need to know what questions to ask. And I'm sure you know how to take a history from a child with anemia, but let's go through some of the features. Firstly, is it acute or chronic? You need to try to understand whether the child's had symptoms of anemia only for a short period of time or for a long period of time, because it can give you a clue as to what the cause is. In young children, it's important to go back over the perinatal history, because often there's been blood loss at the time of birth, say a placental abruption, or because of perhaps from bleeding from the cord or some other reason. Sometimes the pregnancy might be a twin, for example, and it could be a twin-to-twin transfusion. So lots of things can happen around about the time of birth that might lead a baby to be anemic later on in infancy. So if you're taking the history of a young child, then ask about the perinatal history, about things that might have happened in the perinatal period. When you're asking the dietary history, you need to ask both a longitudinal history. What was the baby first fed? How long did breastfeeding go for? When complementary feeding was started? And then also ask a cross-sectional history, like what are the typical complementary feeds that the child eats every day. And so you want to ask a history, particularly about whether or not the child's eating iron-containing foods like meats or green vegetables or rice cereal or other pulses like beans. So those things can, if the diet is very deficient in those, then that can give you a clue as to why the child might have nutritional anemia. Ask a gastrointestinal history, so the presence of diarrhea or the presence of blood in the stools or previous dysentery, for example, or evidence of malabsorption. Those things can be very important. Always ask about drugs or other chemicals the child's been exposed to, because sometimes they can affect the bone marrow function, of course. Then ask about other components of the blood. So in a child who's anemic, we want to know whether or not their platelet count is normal and whether their white cell count is normal. So ask about easy bruising or bleeding, and ask about the presence of infections, either acute infections or chronic infections or recurrent infections, which might provide a clue to some degree of either some suggestion that the white cells are not normal, or there's some other cell lines in the blood, platelets or the white cells, that are also low, like the hemoglobin is low. Then ask about other comorbidities the child might have that might be associated with anemia, such as TB or HIV. A whole range of chronic illnesses can be associated with anemia. And then ask about a family history, because besides the thalassemias, there's lots of other family inherited conditions that can cause anemia. Okay. When you're examining the child, we've also already said that you should try to make an assessment whether the child's sick or well. Then look for, in the areas that you normally look for pallor, in the palms of the hands, the mucous membranes of the tongue, the conjunctiva. Look for petechiae and bruising. Look for jaundice as well, which might be a clue. Some children who are jaundiced look very pale, but they're not anemic. But some children who are jaundiced might have anemia related to haemolysis. And so when you see a child with anemia, then you need to look for jaundice as well. Feel for the liver and the spleen and the lymph nodes, the entire reticuloendothelial system, because they might provide some clue to an underlying hematological problem that's led to anemia, such as leukemia or some other chronic infection that's led to hepatosplenomegaly and lymphadenopathy. Assess the child's growth, because if the child's, again, this goes back to, is it acute or is it chronic? If a child's got chronic anemia, then they'll often have growth failure. And then there are some conditions that are associated with anemia that lead to growth failure, but bone dysplasias, for example, that lead to growth failure and are associated with anemia. And then there are rare conditions, don't worry too much about this, but there are rare conditions that are associated with congenital abnormalities that are associated with anemias. And then importantly, assess the child to see, the anemic child, to see to what degree they're decompensated or to what degree they're compensated. Now, remember I said that this boy looks relatively well, but on his chest x-ray, his heart was almost as big as his thoracic cavity. And so he had a heart rate of 160 and relatively feeble pulses, like low volume pulses, but a very big heart. So that meant that he had maximally compensated for his anemia. So you need to make an assessment, even if a child looks to be well, if they've got a very low hemoglobin, make an assessment of the degree to which they have cardiac compensation or decompensation. And this boy had decompensation because of a very big heart and a tachycardia and low volume pulses, even though he looked reasonably well. So I want to just give a very simple way of understanding the different types of anemias. And I think often we just consider anemia to be a disease, where it's not really a disease. It's just a condition for which there's many diseases, as you know. And I think if you break it up into those where there's reduced red cell production or increased red cell destruction or red cell loss, right, from external red cell loss, then they're the only three broad conditions that can lead to anemia. And there's lots of different types of, lots of causes of each of these. We'll get onto those, but just think about that. Reduced red cell production, increased red cell destruction, or blood loss. So the most common cause of reduced red cell production is simply iron deficiency. the other causes, which are much less common, actually, are folate and B12 deficiency. But so they're what we call the hematinics. So when we talk about is the anemia responsive to hematinics, we're talking about iron, folate, and B12. Then there are some other causes of reduced red cell production. We'll talk more about iron deficiency later, but there are many other causes of reduced red cell production where there's a failure of the bone marrow, not because of hematinic deficiency, but because of some other cause causing the bone marrow to fail. So, for example, aplastic anemia, where the bone marrow is not producing any erythroblasts or nucleated red blood cells, young red cells, and that may be because of some idiopathic cause. They may have idiopathic aplastic anemia, or it might be drugs or some congenital cause of aplastic anemia. Probably more common than aplastic anemia is the replacement of bone marrow by either malignancy or some leukemia that will cause anemia. Chronic infections are quite common as a cause of just slowing of the production of red cells by the bone marrow. So in TB, in renal failure, in chronic infections like chronic osteomyelitis, there's often just a slowing down of the red cell production. And that's why many children with chronic infections like chronic osteomyelitis become anemic. There's a few congenital problems that lead to the red cells not being produced. So there's one called black fan diamond, don't worry about that, but it's a congenital form of red cell aplasia. So instead of the whole bone marrow being shut down, like occurs with aplastic anemia, where there's low white cells, low platelets, and low red cells, then there's just a congenital form of red cell aplasia. As I said, chronic renal disease, that leads to anemia. The kidneys produce erythropoietin, which is a hormone that stimulates the bone marrow to produce red cells. And when there's erythropoietin deficiency because of kidney failure, chronic kidney disease, then the bone marrow doesn't produce red cells. And so most children who've got some degree of chronic renal impairment will have anemia. And then there's lastly, if you like, a group of conditions where there's increased destruction of red cells within the bone marrow. So it's not haemolysis, but it's what we call hemophagocytosis. Don't worry too much about it, but it's actually quite common in children who've got very severe infections where there can be a inflammatory destruction within the bone marrow, just the same as there's inflammation in many organs. There can be inflammation in the bone marrow too, and that can cause the bone marrow might be producing lots of red cells, but they're being destroyed by this inflammatory macrophage-related process in the bone marrow. Don't worry too much about all that, but try to identify the children that have reduced red cell production from hematinic deficiency or from bone marrow failure. And I'll try to give you an easy way to make that distinction in a minute. The second cause, we said there was reduced red cell production or there's increased red cell destruction. That is red cell destruction within the blood. And basically there's two types of that, either immune red cell production where there's antibodies linked to red cells and they are then destroyed by the spleen because they're combined with the antibodies, and the spleen recognizes that antigen antibody complex. So autoimmune hemolytic anemias, which are not very common, and then there's non-immune. So some of the conditions that you know about, like G6PD deficiency, that's a form of non-immune hemolysis, right? It's not related to some antibody or autoimmune process. It's related to an enzyme defect within the red cells. So it's a congenital enzyme defect. And then there are some defects of the red cell membrane. So there are enzymes within the red cells, and the membrane also can have defects, and that can lead to hemolysis. So anything that leads to an abnormality of the red cell membrane, which might lead to a different shape to the normal red cell shape, can lead to hemolysis, because the red cells, the red blood cells are the shape they are because it's the lowest traumatic way to pass through tiny blood vessels through capillaries and veins. the red cells are shaped that way so that they're least likely to be traumatized by going through capillaries. But if there's an abnormality of shape, then they're more likely to be traumatized, and there'll be mechanical trauma to the red cells as they go through the capillaries. So a number of congenital forms of spherocytosis or elliptocytosis, and these conditions are relatively common in PNG because they are a bit more protective against malaria. So G6PD and spherocytosis are a bit more, they provide some protection against malaria, like thalassaemia. Then there's the hemoglobinopathy. So thalassaemia, which is not a problem of the red cell enzymes or the membrane, but a problem of the hemoglobin itself. And then there's this condition called sickle cell disease, which is very rare in PNG. It's only been described very briefly in a combination with thalassaemia. Oh my goodness! It says this talk will end in 10 minutes. We might have to go off and come back in again, I think, in about 10 minutes. So if the talk cuts out, can you please just log on again with the usual presentation and the usual Zoom link, and we'll keep going with the talk. And then there are physical forces on, I think this is encouraging me to upgrade my Zoom, but we'll see how we go. So if it falls out, then I'll get on again, and you please just get onto the Zoom link again. And then sometimes there are physical forces within blood vessels that lead to damage to red cells, like in malaria and in sepsis. There are physical forces that damage red blood cells. So this is what I wanted to just go through with you. We'll see if we get time in this session, in this brief session. If the Zoom link falls out, please just come on again. When you're looking at a child with anemia, then you do the history and the examination that I've described, and then have a good look at the full blood count. And the child will have a low hemoglobin because they're anemic, but you need to then look at their MCV and see if they've got microcytosis or enormocytic anemia or macrocytic anemia. And most commonly, the most common types of anemia are microcytic anemia and normocytic anemia. Macrocytic anemia is relatively uncommon, and it usually occurs, of course, with folate and B12 deficiency. And that can be mostly nutritional, but sometimes it occurs where the parent, the mother, has B12 deficiency and breastfeeds her child. So she's got no B12 to give the child. So that's the only real cause of macrocytic anemia. Much more common, as I said, is the low MCV and microcytic anemia. And when you're looking at a child who's got microcytic anemia, then the next thing to look for is the red cell distribution width, RDW. Now, I've talked to you about this before, but it's a measure of the variability of the size of red cells. And when you've got iron deficiency, there are some small red cells, very small, and there are some that are a bit larger or normal size. So there's a large variation in the distribution width of the red cells. And so there's a high red cell distribution width. That is, there's a wide variation. And this is important. In iron deficiency, there's a very high red cell distribution width. And the amount of red blood cells will be low. I mention that because when you've got thalassaemia, it's a bit the opposite. Usually there's a normal red cell distribution width, and there's a normal red blood cell number. The hemoglobin isn't as abnormal, but the red cell number is normal. Whereas in iron deficiency, the red cell RBCs are low. So high RDW and a low RBC. And if you can measure it, measure the reticulocytes, and they will be low or absent when you've got iron deficiency. It sometimes will be high or normal in thalassaemia, depending on how the state of the bone marrow. So then after that, a high RDW, low red blood cell count, low reticulocytes, take a dietary history and take a history of blood loss, and you can very well establish a diagnosis of iron deficiency if you have all these things. Whereas if you have microcytosis and a normal RDW and normal red blood cell count, and the child might have some other clinical features of thalassaemia like splenomegaly or frontal bossing or hepatomegaly, then it's likely the child's got thalassaemia. Now, of course, we'd like to do a hemoglobin electrophoresis, but mostly you can establish a diagnosis of thalassaemia on clinical grounds, or you can establish a diagnosis of iron deficiency on clinical grounds. Now, I think the call will drop out soon, but if it does, please just get back onto Zoom as soon as you can, and we'll keep going. If the hemoglobin is low and you've got a normal MCV, then that's normocytic anemia. And this can be divided into two forms. One where you have a high reticulocyte count, and what that's telling you is that the bone marrow is producing lots of new red cells, right? So the bone marrow is working, but it's producing a lot of red cells. And so that suggests that there's some destruction of red cells in the blood, that the bone marrow is working, but the red cells are being destroyed. Whereas if the red cells, if the reticulocytes, which are the earliest forms of red cells, if the reticulocytes are very low or absent, then that suggests that there's bone marrow failure, right? And sometimes when you've got high reticulocytes, they'll have other evidence of haemolysis, that is destruction of red cells. The bilirubin will be high, there'll be splenomegaly. And so that's how you can establish a diagnosis of hemolytic anemia. Whereas if the reticulocyte count is low, then you can establish a diagnosis of bone marrow failure. And then you can think about the different causes of bone marrow failure, such as signs of leukemia, or chronic kidney disease, or TB, or you take a drug history and look for different causes of bone marrow failure. So I think this schema for making diagnoses of anemia doesn't include fancy tests. It really just includes the history, the examination, and a really detailed look at the full blood count, looking at all the different red cell parameters. And if you go through that, then the majority of types of anemia you can make a diagnosis of. And then, of course, some you need to have bone marrow aspirates, or you need to have other tests done. But I think mostly you can come to a diagnosis of anemia, the type of anemia, by looking at the full blood count. So just to be clear again, when your MCV, if you've got iron deficiency, you'll have a low MCV, you have a high red cell distribution width, your red blood cells will be low, and your reticulocytes will be low. If you've got thalassaemia, then your MCV will also be low. It's microcytic anemia, but your red cell distribution width will usually be normal. The red blood cells, the number of red cells will usually be normal, but your reticulocytes will be normal to high. If you've got hemolysis, then MCV, it's usually normocytic anemia. So your MCV is usually normal. The RDW can often be high because you've got lots of different shapes of red cells, because they've been destroyed by whatever is causing the hemolysis. And so you have some elongated cells and other things. So your RDW will be high. The red cells, the number of red cells will be low because they've been hemolyzed in the blood. And the reticulocyte count is usually high when you've got hemolysis. If you've got B12 or folate deficiency, the MCV will be high, usually over 90, sometimes over 100. Your red cell distribution width will be high because there are some very big cells from your macrocytosis, and there are some normal cells. Your red blood cell count will be low, just like in any other hematinic deficiency, like in iron deficiency. And your reticulocyte count will be low because the bone marrow can't make red cells, enough red cells, because of low B12 and folate. And if you've got a chronic disease causing bone marrow failure, the MCV will often be normal, a normocytic, normochromic anemia with the normal red cell count. And the red blood cells are often low because the bone marrow is just not working properly. And the reticulocyte count will be low because, remember, reticulocytes are the immature new forms of red cells. Okay. All right. I think we've got 1 minute to go. And then if you can log back in, we'll keep going. This is a blood film which simply shows what I'm saying about this is in iron deficiency, and it simply shows the features of iron deficiency, where you've got what we call target cells, which are often very small cells that are really pale in the center, and sometimes they look like a bit of a target, but they're often small cells that are pale in the center. Some cells that are elongated, they're a bit pushed out of shape, just because they're weaker red blood cells. And so the main thing is to be able to recognize iron deficiency. Lots of small pale cells with some target cells and some elongated cells. Sometimes you hear this word poikilocytosis, which just means a variation in size and shape. And so where there's poikilocytosis of red cells, there'll be a very high red cell distribution width. Okay. I think we're about to stop. This is about to stop. So we'll keep going until